Hey, this is Pastor Jon Lee, and you're listening to the Daily Sabbath Podcast. Hey guys, Pastor Jay here. Hope you guys are having a great start to your holiday season and Advent. I know around my house, we're definitely starting to get into that Christmas mood. I find myself wanting to watch the movie Elf like every day. I'll probably watch it at least 2 or 3 times before the end of the holiday season. But thank you for joining the Daily Sabbath podcast. And we have a pretty serious topic today. We're talking about depression. And so, it's a serious topic. It's an important topic. And so I do want to give you guys a content warning that if you are sensitive to the topics of mental illness, depression, even suicide, that you would just be aware as you listen to this interview. But before we get into this very serious topic, maybe just a little bit of lightness and a little bit of housekeeping. So 2 items. The first is for those of you guys who listen to the podcast on Spotify, you may have noticed that Spotify released their 2021 wrap-ups this week. And so a lot of people have been sharing that. Basically, they're kind of like Instagram stories, and they show you kind of what the top music was that you listened to this year, or even what podcasts you listened to. And so on my side, it tells me that there's at least 4 of you guys who the Daily Sabbath podcast is your number 1 listened to podcast this year. And I know there's others of you who the Daily Sabbath podcast is in your top 3. And so if that is you, would you share a screenshot of that with me? I would love to be able to know who you are and just give you some sort of recognition and thank you for listening to the podcast this year. And so you can email me a screenshot at dailysabbath@gmail.com. Or if you follow us on Instagram, you can post a story and tag us, or you can DM me that screenshot. But I just really want to be able to thank you and recognize you for being one of our top listeners. And the second thing is just if you are a musician and you have recorded some Christmas music, whether they're singing or it's just instrumentals, and you would allow me to use that music and share it on the podcast, would you email me at dailysabbath@gmail.com and just let me know that you have some music for us? And so with that being said, let me share with you this very, very important interview that I did with Dr. Jon Lee about depression and what Christians should know about depression. And, this is a topic that I think I've had a lot of questions about for a long time. And so it was really nice to be able to sit down with somebody who is a professional who actually treats people with depression, but is also a believer and a follower of Jesus. And to really just ask my questions about, what is depression? How do you guys actually treat depression? What are the expected outcomes? And what are some things that we as Christians misunderstand about depression? And so please listen to this interview with open ears and open hearts. Okay, so today we are talking about a pretty heavy topic. We're talking about depression, and specifically, what should Christians know about depression? And I think, all of us have varying degrees of experience with this. Some of us maybe, we have somebody in our lives who we're close to who has experienced depression. Maybe we have even ourselves experienced depression. But still, maybe some of us, we really have very little experience, very little understanding at all of what depression really is or what it looks like in a person's life. And so, I think we're all coming from different places on this conversation, but I think something that we can agree on is that this is a topic that's important. That I was just looking up some statistics online, and about 15 million Americans experience some level of depressive symptoms every year. And nearly 90% of those people report, serious difficulty with work or home life or other relationships in their lives. Suicide is actually the 10th leading cause of death in the United States. And so, this is a topic I think that is definitely worth talking about, something that is becoming more and more relevant in all of our lives. And the reason why we're talking about this in the context of, what Christians should know about depression is because I think there are varying degrees of response to this topic from the Christian community. On the one hand, you have some Christians who really just see, depression, it's just a spiritual problem. People basically just need to pray more, have more faith, and they'll be healed. And then on the other end of the spectrum, I think you have people who believe that depression is purely, biochemical. It's really just medicate and you'll be great, right? And we'll send you on your way and you'll be fine. And so, there's a pretty wide spectrum of understanding about what depression is and how you treat depression. And so today, my guest is someone who I think is perfectly poised to have this conversation with us and give us a really important insight. His name is Dr. Jonathan Lee. He is a licensed psychiatrist who is both a clinician, so he's practicing, he sees patients, and also a researcher working with people experiencing depression. And he's also a committed Bible-believing person of faith, a follower of Jesus Christ. And so I couldn't think of a better person who could maybe lend some knowledge and insight to this topic. And so, Dr. Jon, thanks so much for being on the podcast.
Thank you so much for having me, Jaya. It's very generous.
And now something else about Jon. Along with being a psychiatrist, he's also a really good singer. We happen to belong to the same faith community, and he on occasion is a worship leader and can sing a mean harmony. So he's a multi-talented person. But so Jon, just to start off, could you tell us a little bit more of the work that you do and sort of the line of research that you're in?
Yeah, absolutely. I mean, I think my career has taken a few different unexpected turns recently. Right up until July this year, I had been doing a lot of research in transcranial magnetic stimulation, or TMS for short. And this is a novel brain stimulation intervention specifically used to treat treatment-resistant depression. So people who've tried medications, they've tried therapy, maybe have tried other different modalities, and have not really gleaned that full benefit. So a lot of my publications, the few that I have been focused on optimizing transcranial magnetic stimulation for those who are depressed. My current line of work, I'm really focused on being a clinician. I kind of took a bit of a step away from academia for a variety of reasons, mostly personal, to try to have a bit more time and agency over my own schedule, but I continue to work with students at USC in student health, and I also have my own private practice at Oak Health Center.
All right, so let's get down to sort of the nitty gritty. Like, how would you, as a clinician, how would you define what depression is?
Yeah, I mean, I think, as psychiatrists, psychologists, mental health professionals, really the definition of major depressive disorder, or depression for short, is found in the Diagnostic and Statistical Manual, and currently we're on version 5. And so essentially there are 9 cardinal symptoms that really define it. The two sort of A criteria or most important symptoms would be, of course, 2 weeks of either very low sustained mood, so feeling really sad, blue, down in the dumps, like sustainedly low, and or also anhedonia, so this lack of pleasure, interest, motivation, things that used to bring life, and verve really feel a lot more bleak and gray. So typically there's one, if not both, of those symptoms, and the remainder of the symptoms can be sort of classified into these 2 sets. So they're the bodily or neurovegetative symptoms of changes in sleep. Sometimes it's up, sometimes it's down. Changes in energy, changes in appetite, again, sometimes up, sometimes down. And also this curious malady called psychomotor retardation or agitation. So that's where basically people might seem a lot more restless or antsy physically, and their peers, their friends, their coworkers notice that, or they might actually appear a lot slowed down and subdued, and you'll hear this in the tenor of the voice and also the pace of the speaking, and also the speed of responsiveness. So those would be the more neurovegetative or bodily symptoms, and then the remaining 3 neurocognitive symptoms would be symptoms of indecisiveness or difficulty concentrating, thinking, sort of remembering things, as well as low self-esteem, guilt, just like ruminating on past sins, on past things that people feel, really defining in their lives, often, blowing these usually more banal kinds of events into this huge catastrophic kind of proportion and ruminating on it day in, day out. And then, of course, the most salient and most dangerous symptom of depression is that of suicidal ideation. And so that can range from, on the milder end, just nihilism, like what is the meaning of life anyways, or I wouldn't really mind if I didn't wake up tomorrow, all the way to having a really concrete, methodical, thought out suicide plan. And so, of course, that's the biggest, most dangerous potential effect of this disorder that unfortunately is an outcome for many people who have depression.
I see. Yeah. And so, I mean, it's kind of helpful to hear, like, when you're sort of describing sort of what these symptoms sound like out of the mouths of the patients, and so I don't know if you can kind of maybe even give us a few more examples just to kind of put some more flesh and blood on it, like kind of, I'm sure that when you're seeing clients and you're kind of talking to them and sort of assessing where they're at in terms of these different symptoms, like what might be some typical things that you hear coming out of the mouths of some of your patients where, you kind of get a sense of, okay, this is, this particular symptom or whatever. Like, would you be able to like maybe describe that a little bit more?
Yeah, definitely. I mean, I think, again, like idioms, forms of expression really vary from individual to individual, but like obviously the trope or the metaphor of the black dog has been around for a while. This idea of a weightiness or a mental fog or pressure, typically people who are otherwise really, really bright, motivated, high achieving, when they're hit with the Mack truck of depression, it just becomes harder, to sort of stay on track and organize. Doctor, I sit down and I have 4 hours where I know I need to study biochem, but I just read the same sentence over and over and over again. Or, I find myself not wanting to go to yoga, not wanting to go to church, not wanting to go to hockey practice. Like, what's the use? What's the point? And so the common themes, that kind of come up again and again are these themes of like a malady of the self, like I'm a terrible, crummy person, I'm worthy of punishment, issues with the world at large, like the world is a terrible, scary, dangerous place, and it's really, nobody really is out there for me or to support me. And then also forecasting, these difficult circumstances into the future, presuming that there's going to be a really miserable outcome to your test or to your proposal or to your presentation at work, and just assuming that nothing can really get better. And so, depression, it really shows up in a myriad number of ways, and it's quite complex, but those would be, I think, the typical themes that come up in people's speech.
And then do you typically, when you're kind of assessing your clients, are you assigning some sort of, like, are there different levels of depression that you kind of like assess or assign to a person?
Yeah, absolutely. So the DSM-5, sort of has these different specifiers. Is it a single episode? Is it recurrent? Obviously, a person with a history of recurrent depression is at a higher level of risk for treatment resistance than a person who's at a single episode. And then there are sort of mild, moderate, and severe. So, the threshold number of symptoms would be 5 out of 9. So anywhere between 5 to 6 symptoms would be, considered mild. And then 7 to 8 would be moderate, and 8 or 9 and above would be severe.
I see. So yeah, I mean, that's super helpful just because, I'm coming at this as, I think if you're not a therapist or you're not trained in these things, like, and you've never maybe gone through therapy yourself, like, I feel like, at least for me, this whole process is just like, I have no real sense of what happens, right? And I think for maybe a lot of people, even a lot of Christians, like, it's just kind of opaque, the process, and we don't really know what happens behind these closed doors. And so I think that could be part of what fuels some of the misconceptions or suspicions that some people might have. And so it's really helpful to kind of just hear all of these things. And so I guess my next question then is, like, to really pull back the curtain of, like, how do you actually approach treating a person with depression? And, along with that, like, what are your expected outcomes? Like, are there any like statistics that you can share with us? But yeah, how do you treat someone with depression?
Yeah, I mean, I think that's such a great, it's a great question. It's a very broad topic. I think I'll try my best to do justice in the time that we have. I think, really everything in psychiatry boils down to, that assessment, that ongoing relationship that you have with the person in front of you. And I think without having taken the time to really hear what's going on in this person's life, really it's hard to make recommendations, or at least that's just the way I practice. And I think it is like that iterative process of like building trust with the person, making sure that you really are listening, understanding all the different stressors unique to them, be it in their relationship, their marriage, finances, work-related stressors, academic pressures, immigration, all of these racial tensions, marginalization, like appreciating to some extent the depth and the breadth of this person's unique experience is definitely the starting point. And then I think, psychiatrists were obviously trained to think biologically as well as psychologically. And so the treatments, broadly speaking, would fall into categories of like pills, so like antidepressants, which can range in complexity and in cost. But the, sort of most accessible generic versions of the selective serotonin reuptake inhibitors are highly effective. They've been around since the 90s. The risk-benefit profile is really favorable. And so generally things like fluoxetine, sertraline, or escitalopram would be reasonable bets as a starting place for medication for a person who's never been on one before. And then, for many people, if philosophically or just otherwise, they're sort of skeptical about medications and the pharmaceutical industry. By the way, I have no connections to pharma. Nobody's funding this talk. So
you're not working for any of those medication companies, those medications that you named.
Nobody's going to ship me off to a Swiss ski lodge after this. So, I think depending on the person, there are also, of course, psychotherapy options. I think depending on the kind of home church that a person comes from or the cultural context, there can be varying degrees of skepticism. But, I think a core first-line treatment for anybody with depression would be something like cognitive behavior therapy, which is basically a modality that calls us to reflect on both our thoughts, our cognitive, cognitions, our behaviors, behavioral, sort of aspects of depression, and to kind of shape or challenge or wrestle with these aspects of depression. Mm-hmm. And, depending again on the severity of the depression, depending on the recurrence, depending on family history, the current stressors, people may elect to do both medication and psychotherapy. They may elect to try various different alternative methods if they've tried these, sort of first-line interventions and haven't gotten much relief. But to your point of like the expectations for outcomes, for somebody who's had a single episode, your first episode, 18 or 19-year-old, going to college, away from home for the first time, acclimatizing, new pressures, new relationships, the likelihood of response with a medication to the first trial is likely in that 60 to 70% range. And then, depending on the response, if you don't respond to the first medication you're on, you've got a probably around 40 to 50% chance of responding to the second medication. And thereafter, the chance of really solid, robust response to a third and fourth medication trial drops off pretty steeply to about the 12 or 15% range. Now, again, that's just based on, staying within a certain class of medications. It doesn't account for combinations of medications, which psychiatrists often can prescribe if warranted. It doesn't account for, additional effects of psychotherapy, all of which can yield incremental benefits on top of that. But again, the party line or the idea of depression, I think globally, is that it is a more chronic kind of illness. that has the opportunity to flare up and then be treated, back into remission, and to come back again, depending on stressors
Hmm.
throughout a person's life.
All right. So I think it's good to hear you say, I mean, so obviously medication is a big part of the treatment, is what it sounds like
Mhm.
to me.
Mhm.
But it's not the only aspect of treating depression, because I'm just kind of speaking to that person who is already,
Yeah,
maybe very suspicious of
yeah,
psychiatry, psychology in general, and kind of has this perception that, what, all psychiatrists do when they're treating people with depression is just write them a prescription for some pills and send them on their way,
right.
right? And that it's purely just like, approached as a biochemical solution. And so
Right.
it's helpful for me, I think, to hear you say that, that there's a balance where basically there is, yeah, the medication aspect of the treatment, but also there's the aspect of, cognitive behavioral therapy, or, just
Mhm.
different counseling methods where you're actually talking to the client, getting to know them, building a relationship with them, helping to just kind of wade through like what are the different things that are going on in their lives.
Right.
And so yeah, that's helpful for me to hear that, to maybe kind of allay some of those fears that some people
Yeah.
might have. And it's also interesting to hear the efficacy statistics on, those treatments. And so yeah, one question that I had as you were talking about that was, okay, so, I think you said that the first time experience with depression, first medication, maybe like I think you said like 40 to 60% efficacy rate,
Probably
and then
closer to 60 to 70, but
oh,
yeah,
60%.
yeah,
Okay, so
around
60
that.
to
Yeah,
70,
yeah.
and then it kind of
Mhm.
goes down from there. I'm just kind of curious, are there any alternatives where, let's say, you find that, yeah, maybe medication is not efficacious for a particular
Mhm.
patient, like, is there any alternatives?
Yeah, definitely. I mean, first of all, I think there's this huge field in psychiatry that is really nascent and developing of like, food as medicine, not only in the realm of eating disorders, but in the realm of depression and other, sort of maladies. But beyond that, the more well studied and established alternative treatments, certainly these days, ketamine, esketamine, they are pharmacological interventions, but they're somewhat different from taking a pill,
Mm-hmm.
because they can be infused or they can be delivered intranasally. There is, of course, transcranial magnetic stimulation, or TMS. That was the realm of research that I was doing in Toronto, at the Center for Addiction and Mental Health, and also at UCLA, where I was previously practicing in the neuromodulation division. That has a really good risk benefit profile. I'm totally biased because I love spreading the gospel of TMS,
Mm-hmm.
in the sense that, if you're on that third medication trial or fourth medication trial, that chance of success is in that 12% range. But
Mm-hmm.
if you are looking at TMS, your rate of response is again bumped to about that 60 to 70% range. So
Mm-hmm.
again, not a silver bullet, but considering this is an option and people do respond well to it and can really reclaim aspects of their lives, with this kind of daily intensive treatment. I
Mm-hmm.
think it's definitely an option to consider. And
Uh-huh.
then, of course, as you escalate up, there's electroconvulsive therapy, which unfortunately was featured in One Flew Over the Cuckoo's Nest by Nurse
Uh,
Ratched in a very punitive way.
mm-hmm.
It is not delivered in that way. At least I have not observed it myself being delivered in that manner. But
Yeah.
of course, it does involve, anesthesia, and you do go under, for a period of time, with an anesthetist present. So there are, of course, risks associated with that. And the long-term outcomes with electroconvulsive therapy, or ECT, are more, at least initially, immediate sort of memory loss in and around the time of the treatment. And then if you're repeatedly getting the treatment, sometimes people do tend to lose some of their, autobiographical memories.
Mm.
But it depends on the density and the type of treatment specifically that they get with ECT. And then
Interesting.
beyond that, there's this huge, sort of, it's not uncharted, but it's like being charted, I guess, territory of deep brain stimulation. And so planting electrodes into the brain, the stimulator, um, that allows, neurosurgeon and psychiatrist in tandem to adjust wave patterns and waveforms, to get a person back into health. So I think the messaging here is that, even though the rates, it sounds like it, the rates of success or response diminish rapidly with medication. Again, there's so many different facets, medication in combination with therapy, dual mechanisms of medications, so like combination strategies. And then, of course, this whole area of neurostimulation that's out there.
Okay. And so, in terms of TMS, because you said that is sort of your specialty, that's your area of research. I'm not sure if the you and I have had conversations about this, but I'm not sure
Yeah,
if the
yeah,
listener quite caught it. But it is a sort of a electrical stimulation, like of the certain parts of the brain, like from the outside. Not
yeah.
You're not inserting anything into their heads, but it's like a sort of an
Yes.
electrical stimulation.
Yes. So TMS, yeah, it is a non-invasive brain stimulation modality. Non-invasive meaning, there's no anesthesia, there's no IVs or needles, there's no surgical cuts or incision. It's been around really since the late 90s, and it is based on that principle of electromagnetism. So I'm not a physicist, but what I understand about it in Faraday's law is that electrical energy can transform into magnetic energy, can transform back into electrical energy. And so in the late 90s, when Mark George and Alvaro Pascaleone, first were able to use these magnetic coils that were developed in Sheffield, England, they were able to place these, they call them figure of eight coils because they look like a figure of eight. So these two ringed magnets on the left forehead of people with depression. And they found that as they gave high frequency electrical pulses into these magnets, the mechanism of action, or the proposed mechanism of action, was that this electrical current would then generate a perpendicular magnetic force field that could penetrate through the skull and then get transformed at the level of the cortex, or the outer kind of bark-like layer of the brain, into electrical current. And so at a depth of about 1 to 2 centimeters deep to the skull, we're sort of tickling the brain and activating, maybe areas that had gone dormant or had been weakened in the state of depression. Again, it's not always clear. Is it the chicken or the egg? Is it that, the brain activity in the left prefrontal cortex decreases before depression, or is coincidental with it, or causes it? Not really clear, but historically there's always been this connection there. And so TMS seeks to balance out in some ways, in an
So basically, try
oversimplistic way.
to increase that activity level in that particular part of the brain that's associated with depression.
Exactly. And if you think about that left prefrontal cortex, it's the most human sort of part of us as humanoids. The prefrontal cortex is very developed in humans in comparison to other species. It is thought to be that seat of executive function or executive control. And so that's where, thinking, planning, memory, attention is all sort of ensconced in the brain. And so we kind of see this, clinically. When people are really depressed, it's like they can no longer punt away those depressogenic thoughts that we were previously talking about. And they become a lot more vulnerable, and receptive in a way to these depressogenic thoughts. And in a state of health, someone might say something critical to us and we'd be like, oh, okay, well, that's your opinion. I'm going to do me.
Yeah. Okay. Yeah, it's interesting. So, yeah. So again, this is not a commercial for TMS. There's no sponsorship here of this
Definitely not.
conversation. But it's just a form of treatment that I personally had never heard of until I met you. So I have two questions. One, is this something that a person should consider requesting? Like if they are being treated for depression and maybe they're not responding to the treatment that they're receiving, whether it be
Mhm.
medication or whatever. Like, is this something that somebody could request from their providers? And if so, like,
Yeah.
what's the likelihood that this is available to them? Yeah, just kind of
Yeah.
curious.
Yeah, absolutely. I mean, I think, again, coming from a Canadian context, it's a bit different because there every, medicine is socialized. And so here in America, there is a sort of labyrinthine system by which different insurance companies approve patients to, sort of receive this treatment. There is a heavy upfront cost related to, technician salaries, the cost of the equipment, everything that comes along with administering it. And so insurance companies are usually somewhat reluctant to just sign off on them. And so I would say if you've been on a couple different medication trials, by the time you're around the fourth trial, you're usually meeting that minimum threshold level of severity that most insurance companies would require you to have met to be eligible for this. Because TMS it's FDA, sort of cleared for use in treatment-resistant depression. It's cleared for use in obsessive compulsive disorder as well. But it remains a sort of niche intervention, which I think is really unfortunate because to me, if a cousin, if a nephew, niece, had depression, I would absolutely recommend this and recommend this treatment to them. But yeah, I think it is sort of not for the faint of heart. If
Oh,
you
really?
are curious to bring it up with your physician, she or he may not even know about TMS, and so part of it is just sort of educating communities and people that this is a potential option.
Okay. So you mean not for the faint of heart, not because of the treatment itself, but because people might not know about it or providers might be resistant to
Right,
give you a
right,
referral
absolutely.
to obtain it. Okay. So this is
Right.
something
I
that
mean,
you
to
might
me,
go ahead.
oh, sorry, I was going to say, like, to me, I think the biggest side effect of TMS is just the onerousness of, like, getting it approved and getting in the chair. Once you start the treatment, and it is a pretty, onerous daily treatment because you show up 5 days a week for, periods ranging from 3 minutes a day up to, over an hour a day. So it doesn't always fit in everybody's schedules, but I have seen, young 30-year-old professionals who come in for their 8 a.m. or 7:30 treatment, 3 minutes of intermittent theta burst stimulation, and they go off to work. They drive themselves. Nobody needs to take off time to accompany them or, monitor them afterwards. And they go on and they live their lives.
Yeah. So you've seen a lot of success
Mm-hmm.
using TMS. Okay. So it sounds like this is something that maybe the patient themselves would have to sort of be their own advocate if they wanted to see if it was possible to get a referral to get TMS. Like they would probably,
Right.
in a lot of cases, have to be the one to bring it up and fight for it.
Right.
For you as a psychiatrist, although obviously you use the various medications that are available to you as part of your treatment methodology, but you also pair that with, psychotherapy and, real like counseling and walking with a person. And,
Mm-hmm.
but would you say that you, like, I'm trying to get a sense of if you are the norm or if you are the exception, right? Like, would you say that maybe it is possible that somebody who goes in and they're referred to a psychiatrist because they're suffering from depression, and they
Right.
very well may get a psychiatrist who's just like, yeah, here's some pills, take these and let me know how it
Yeah.
goes. You know what I mean? Like, how are you the norm or are you the exception? And if so, basically, are patients going to need to fight for somebody who's a little bit more like you?
Oh wow. I don't know. First of all, I don't know if I'm worth fighting for, but
Or at least
but
at least the
enormous.
approach. At least the approach.
Yeah. I mean, I think philosophically for me, whether because I'm a Pisces or Chinese Canadian or what, I've always been a both and kind of guy, and so I don't know how normal that is in America. I can say that like of the colleagues that I've met, in both Canada and here, I would say, clear majority of psychiatrists were trained to handle medication, right? And that's where often our expertise and our comfort level lies. I guess always, been interested in that sort of the art of medicine piece of psychiatry. And so psychotherapy has always been really an intellectual curiosity and passion of mine. And also, of course, I've seen on both sides of the couch, actually, so to speak, the potential benefit of undergoing both brief and longer term therapy. And so I would say entering into a relationship with any kind of mental health clinician, whether purely talk therapy, whether it's quote unquote purely medication, it's always going to have, that relational aspect. And it's so important for people to know that it's okay if you don't click with your first psychiatrist therapist, and to be, willing to kind of shop around a bit before you find someone and really invest the time and energy and finances into your own care, because you got to be able to trust and work with the person who's working with you.
Yeah, I mean, I appreciate you saying that. I think the thing that I'm getting out of this conversation that we're having so far is that, and it's tough, right? Because if you're a patient and you're suffering from depression, maybe your motivation levels are already low, but really to kind of advocate for yourself. And if you feel like, man, I'm just the body here, and they just want to write me a prescription and send me on my way, that it's okay to kind of like, can I talk to somebody else?
Yeah, I mean, I think even in that situation, like, I call me naive or, Pollyannish, but I feel like nothing is wasted, and it may well be for a period of time. You take your fluoxetine or your bupropion, and then, you start to get more energy, your sleep improves, you're feeling more like yourself, and then you're able to benefit from therapy, and so it may well be that at a particular juncture, medication is where it's at, and that later on in the journey, therapy becomes more immediately helpful.
Yeah, that's something. So my wife is actually a licensed therapist, and then that's something that she had told me before. Where sometimes, when they first start therapy, that they need that medication to get them to a level where then they can actually benefit from, more like the cognitive behavioral therapy, the talk therapy.
Right.
But, sometimes where a person is at first, like they just need something to get them at a manageable levels, where all the talking is not going to help, until they get to a certain place. And then it becomes more of a helpful thing. So my next question then is, what do you think people in general, and maybe Christians specifically, tend to misunderstand about depression, if anything?
Yeah, I mean, where to begin with this one?
Opening up a bag of worms.
Yeah. How much time do we have? No, I think, the people that I've seen, and just to give some context, in Toronto, it's really multi-ethnic, very diverse people from every nation, tribe, and tongue are found in Toronto in many ways, and in LA as well, depending on the place that you're at. And I think, well-meaning parents, friends, family members are just sort of peddling this belief that, you just need to buck up, or you just need to go out and get some sunshine or exercise. A lot of people, in their efforts to try to, quote unquote help, tend to give unwanted advice, or have not done the work of establishing that sense of trust or understanding, empathy or validation before they start down those roads of, well, you just need to pray. You just need to pray it away. Or here's a great Bible verse and 5 points on how to combat depression from, insert mega pastor from church here. So I think the general missteps that I've observed from my perspective have been people who have really wanted to help, but perhaps have come off a bit tone deaf with the people around them. And that's for good reason. Again, I think people just don't understand the depths to which depression can affect a person, on a deep soul level, like a biological soul level, in the throes of depression. It's like, you don't feel things, right? Like there is no more energy or drive or joy or mirth. And so, in that state, I think having a friend tell you, look on the bright side, or,
Mm. Yeah.
think positive. It's just sort of like
The
adding
glass is half
fuel.
full.
Right. No, it's really full. It's sort of like, it reminds me of that, Job and his friends, right? The miserable comforters who are just so hell bent on finding an explanation or finding, a cogent reason. And I think a lot of us, Christian and not, are just often uncomfortable with the possibility that sometimes suffering just is, sometimes it just is. And we may not be able to find on this side of eternity a really cogent or tidy explanation.
Yeah. And so, here's my question, because I think I'm always on the other side of the spectrum, which is like, I don't want to be that person who says something really dumb or hurtful to somebody.
Mm-hmm.
But
Mm-hmm.
for me, then, a lot of times I feel paralyzed. I see
Right.
somebody that I care about is hurting or suffering, or
Yeah.
maybe but I
Right.
don't want to be that fool who just, hurts them. And so, like, a lot of times I'm
Right.
just like, I can't say anything. Like, I don't know what to say, right? Or I don't know what to do. So, like, I don't know if you
Yeah.
could kind of maybe coach us up a little bit. And
Yeah.
every situation is obviously different, but if you could just
Yeah.
coach us up a little bit with some tips, like, what are some maybe helpful ways then to try to approach our friends who we suspect are going through depression or, whatever?
Right. Well, I mean, I think, and it's what comes to mind of all things is like, Beyonce, right? Like, listen
Beyonce.
to the song inside their hearts, right? Like that, like being willing to kind of roll up your sleeves
Uh-huh.
and sit down, like sit in the ash heap with someone, and really just ask those questions and make those observations, like, hey, I how are things going? Like,
Mm-hmm.
tell me, like, what's happening in your life, and like read the temperature of the conversation if the person's really not willing.
Mm-hmm.
Sometimes just saying, like, I'm here for you, I'm with you, whether communicating that with words or with not, like in different nonverbal ways, showing that you care, showing up. I think that can be really helpful. I think
Mm-hmm.
asking questions and validating people's emotions is so important. So a lot of times, unfortunately, people who are trained therapists as well have this kind of like writing reflex. Um, I mean, I
What does
think
that
of my
mean?
own Asian mom. My own Asian mom. It's like, oh, I'm just feeling really, really sad. Well, what do you have to be sad about? I mean, you
Oh,
have
I
a
see.
house and you have a good job and a beautiful wife, and it's like,
Yeah.
okay, hold up. To be able to sit with someone and to say that sounds so tough.
Mm-hmm.
I can't begin to imagine what that's like for you. Um,
Mm-hmm.
you know, like, how can I support you?
Mm-hmm.
Versus like, I'm going to make sure I pray for you there and a pat on the back. Um,
Mm-hmm.
I think it's what's important to also keep in mind is that sometimes people with depression, they can push people away, right? Like, part of the nature of the beast is like, we lose that mirth from engaging with people on those deep friendship kinds of levels. We stop going to the art galleries. We don't go, out for dim sum anymore. And so the actual texture and beauty of life and our relationship starts to go away, which then again, leads to a bleaker kind of existence. And so if you suspect that someone is kind of dealing in the throes of depression, I think encouraging, texting, saying like, hey, I'm going to catch this movie over this weekend. What's your schedule like? Want to meet up? Want to grab a bite to eat? I think can be helpful. There is, of
Mm-hmm.
course, a line where it can, if it's like every moment, every day,
Uh-huh.
like that's obviously not the tenor unless you're really, really close with the person. I
Hmm.
don't know if this is very helpful at all, but I think just keeping in mind, you know, listening more than you would
Yeah.
anticipate would be helpful. Um, Being as mindful as possible to validate, without having that writing reflex or the immediate, like, I think the glass is half full
Yeah.
kind of mentality. There is a place, there absolutely is a place, for believers to pray together, to seek biblical wisdom together. I think for many of us, though, we tend to default to that because
Hmm.
we've never been comfortable with
Yeah.
sadness or lament.
Hmm.
And I would say, if anyone is curious, I think to spend a lot of time in the Psalms might give a window into what that experience can be like.
Hmm.
Um,
So, I mean, it just sounds like really listening well and listening fully. Yeah, because I think you're right that sometimes maybe just because we're uncomfortable and we just don't really even know what we're supposed to say, and we're trying to be
right.
helpful, but we very quickly try to jump to an answer, or very quickly
Yeah.
jump to, well, let me pray for you, or here's a Bible verse, or whatever. So it sounds like maybe the biggest thing that we can do for somebody is to really fully listen to them and let them fully be heard,
Yeah.
and affirm
Absolutely.
their experience as much as we can.
Absolutely. Communicating with words and without, like, I see you, I hear you, brother, I love you. I don't have the answers. I don't know the right thing to say, and I'm with you here. You're not alone. I
Mm.
think is the place to be.
Is there any other things that you feel like Christians specifically tend to get wrong when it comes to depression?
It really depends on the unique church context. I mean, I certainly think that it can be frustrating for me as a Christian psychiatrist to hear people in tears tell me my pastor said this to me, or my grandmother told me, she wouldn't talk to me if I saw a shrink, or
Mm-hmm.
these kinds of barriers that I think, again, in our efforts to be good Christian people, or Bible believing people, it feels almost like we're disobeying or betraying God, or we're disbelieving if we seek help
Mm-hmm.
outside of the church, outside of a Bible counselor, outside of, a pastor. Like, all other sort of soul help is suspect. And I would say, people who are going through depression probably already have enough,
Mm-hmm.
self doubt, criticism, guilt to begin with. And to just heap that additional layer on top of it is just it's so brutal. So I would say, even if you have these judgments, by all means have those judgments and keep them to yourself.
Mm-hmm.
Or remember that, like, if your mother had cancer and you philosophically didn't believe that chemotherapy or radiation oncology was like the way of God to help her cancer, maybe you could suspend your disbelief just long enough so that she could seek out consultation and make up her own mind.
Yeah.
I think there's this dichotomy that often gets perpetuated within the church and without, like, like psychiatry, psychology, anything that's not a biblical counseling session is suspect. And I think that
Mm-hmm.
really ends up hurting people made in the image of God, because they end up feeling guilty seeking common grace and wisdom that is distilled down through medical knowledge that is available to everyone made in God's image. And so I
Yeah.
think the more that we can kind of support our brothers and sisters to seek excellent care, and to alleviate that burden of guilt and shame that has probably already been there, depending on the context, for many years, the better we do by them.
I think that is, just such an important point that, yeah, I mean, there are a lot of kind of sections of the Christian community out there that do view, psychology or psychiatry, these kinds of medications
Mm-hmm.
as being somewhat suspect. they're not sure what to think about it. I guess there's probably a range, but ranging from this is not of God to I'm not sure what I think about this, but I'm suspicious,
Right.
right? But I
Right.
like what you said there. It's not that they can't hold on to those. If that's what you believe, that's fine. But if you have a friend or a family member who is suffering, right, and
Right.
they're just trying to do anything and everything they can to find some way to feel better, and
Mhm.
you are taking your suspicions about psychiatry or whatever, and you're heaping it
Right.
on them with this guilt and basically closing off this potential means for them that maybe they would be open to, but because you're putting so much guilt on them that they're kind of
Right.
closing themselves off to it. That yeah, that I mean, I wouldn't want to be that person. I wouldn't want to be that
Right.
person who puts that kind of a stumbling block in front of somebody who could potentially benefit from something, but because I have this ideological belief that may or may not be true, right? And it's like, and I think you
Right.
make a good point. Like if that same person was sick, are they going to go to the hospital? Are they going to see a doctor? Are they going to get some medicine?
Right.
Right? And
Yeah.
but we want to heap all this guilt onto this other person who's seeking this other type of medical aid that could
Right.
potentially help them, but maybe they won't consider because their pastor and their Christian friends told them that it was bad. So yeah, I
Right.
really think that that point that you made is so important. I don't know if anybody here is listening to this who kind of comes from that mentality, but I hope they will take that to heart. Okay, so I think my last question then is, if somebody is listening to this today and they think that they are suffering from depression, what is the first thing that you would recommend that they do? What should they do right now?
Yeah, I mean, I think knowledge is power, and I think doing a quick Google search, looking for the quiz, the quick inventory of depressive symptomatology online, you can fill it out. It's like a 9-question survey, and it will give you a lay of the land of the depressive symptoms right there. I think seeking professional help usually takes time. And so, depending on your HMO or network, it would be reasonable to book an appointment with your primary care provider, to express to her, him, like those concerns, and to begin that dialogue and that discussion. Provided that the referral is made to a psychiatrist, I would say don't delay, in the sense that if you do decide to go down the route of medications usually take several weeks before they have their full effect. Most people get some relief within those first 2 weeks of starting a medication, but the
Mm-hmm.
full effect won't happen until 4 to 6, even longer, after you've gotten to that optimal dose. And there may be multiple dose titrations before you get there. So I would say that depression piece, if you're concerned about it and you suspect that you have it, act.
Mm-hmm.
Now, there are many things that people can do across the board, that can be helpful from a cognitive behavior therapy standpoint. Even using this method of behavioral activation can be very helpful. Many people who become depressed, they learn to be passive. They learn that nothing they do really helps. And so they stop the drawing, they stop the church small groups, they stop, dim sum. And then the thing is, when we do become depressed, we may not enjoy these aspects of life as much as we did when we were not depressed, but we may enjoy life just a little increment more if we
Mm-hmm.
continue to do these things than if we were to simply sit in our room and watch the paint dry. And so, if there's any agency, energy, autonomy that you can do, I would schedule activities in your day that you could look forward to, things that either bring joy, and or a sense of mastery. Like, yeah, I folded the laundry, or yes, I went
Mm-hmm.
to Trader Joe's and I picked up the groceries for the week. And also, like, yeah, I attended small group. I really didn't like what was made at the potluck, but I enjoyed some of the conversations. Just to sort of keep connected. Um,
Mm-hmm.
Obviously, I would say across the board, if suicide is on your mind and you are contemplating, there are several resources beyond your community emergency department. mobile crisis teams, depending on which county you're in, that will come to you and perform an emergency assessment. It can be quite bewildering. I often like to say that nothing can get better if we are dead. And so in the moment of, thinking about those final moments, I think it's useful to have multiple safety nets in place. Tell your family, tell that trusted friend, tell that trusted pastor, because often we think we need to go it alone, and it can be really, really bewildering and tough to do this on your own. So I would seek out those people around you who are willing to be there for you, at 2 a.m. in the morning, and who aren't going to judge you, and to start to even make like a list of who those people are, to go from there.
Now, I mean, while we're on this topic, I feel like I have to ask this question because I think I've been on the other side of the coin where, as a pastor or just even as a friend, having somebody come to me and basically tell me that, sometimes they think about suicide, right?
Yeah.
And just being completely unequipped to know what in the world should I do with that, right? Other than listen. And so, if we could just, I mean, since we're on the topic, I feel like I have to ask this question. So if I am a friend, right? So I'm obviously not a licensed therapist or anything like that.
Yeah.
If I have a friend who tells me that they're thinking about suicide, do I just continue to listen? At what point is it like I need to, even if maybe they asked me not to tell anybody about it or something like that, right? Like at what point do I need to be like, I need to escalate this conversation to somebody else because, this is beyond me, right? Because, there's sort of that tension there, right? Because this person is coming to you in confidence,
In trust,
thinking
in
that you're that safe
confidence.
person. But at the same time, I'm like, at some point, don't I need to tell somebody about this? And so when is that point where I got to tell somebody, and then who do I tell?
It is such a tightrope to walk. I think even as a clinician, it's like there are very clear bounds or limits to confidentiality, and in moments of safety or lack thereof, I think it's important to be willing to, be disliked by someone if it will hopefully encourage their safety. Meaning, I would have a low threshold to seek help from another person, consultation from, any mental health professionals within your church or your social circles. Again, mobile crisis can be very helpful. Local police to run safety checks. But I think beyond talking, sort of keeping the conversation going, just thinking in the back of your head, like, does this person have intent? So there's a very different level of risk when people think, man, life is so brutal right now. I'd really rather not wake up tomorrow, versus, I've been thinking for the last few weeks, and gathering implements, gathering pills, doing some research, this weekend when my parents are gone and I'm alone, at that level of risk, it's
like they have a plan.
You pull out the stops, right? The goal is at that moment in time to keep them alive. And so that almost certainly will involve getting support and help. And I think the thing for even people who have gone to school for this and like dedicated their lives to mental health and depression, I think we all do need support, because it is a really hard philosophical and spiritual tension when it comes to these life or death questions. And so to not be afraid to reach out in the short term and the long term to seek counsel as the friend who's being confided in would be the message I'd like to convey.
Yeah, so it takes a lot of discernment, but it sounds like if it's a situation where the person is talking about suicide and they have like a plan in place, they're making plans, they have like a method or a time or gathering resources, then that's definitely like, okay, need to escalate this for sure. And then you were saying that Like, I guess I'm just trying to think, like, it sounds like there's numerous people I could call, but who's the best person to call, you think? Like 911 or like these mobile crisis teams? What would be your first call?
Yeah, it is. It's tough. I think if you're with the person at a coffee shop and they're disclosing this, it's like, dude, let's go to urgent care. Let's go to
Mm-hmm.
the emergency department. No, 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 I'm not going to go there. It's like, okay, well, there are these mobile crisis teams. I think we could call them. I care for you, man, and I want to make sure that you know that you're alive, tomorrow, because I think things can get better, but not if you're dead. And so just reiterating, like, okay,
Mm-hmm.
so this is a limit. I'm not doing this to punish you or to betray your trust.
Yeah.
And I can't afford to just be flippant about
Mm-hmm.
this.
Yeah.
And so, yeah, I mean, if it is like calling 911, then it's obviously a case by case basis.
Yeah.
Um,
And we'll try to include some links or some numbers in the episode description. But
mhm.
Jon, thank you so much. I mean, I know obviously this is not a pleasant topic to talk about or even think about. I
Yeah,
I don't think any of us want to even imagine being in this situation,
right.
with somebody we care about. But it's so important for us to to think about it and to have some plan in place and to
Yeah,
prepare ourselves, arm ourselves with information so that we don't accidentally hurt people
yeah.
who are going through depression. Or if you're listening to this and you're suffering from depression, or you think you're suffering from
Mhm.
depression,
Mhm.
hopefully you're hearing something here that might move you to action, move you to seek out some sort of help. And so, but yeah, Jon, thank you so much. Really appreciate just your time and everything that you were able to share with us today.
Totally. Thanks so much for the chance.
All right, so there is the interview. I want to thank again our guest, Dr. Jonathan Lee, and just sharing so openly with us. And, this is one of those things where you don't want to think about it, but you have to think about it because it's so important. It kind of reminds me of the feeling that we got as expecting parents that we had to take these infant CPR classes. And honestly, it was so hard to even want to think about that. And we couldn't get through the lessons without tearing up because we're just thinking of how horrible it would be to be in a situation where your child was choking or suffocating. And so this topic is a little like that. We don't want to have to think about anybody we care about being depressed or even having suicidal ideation. But we have to think about it if we want to be prepared. And for those of you guys who are listening, I know that Christmas time is, a time of cheer, but I know that sometimes these holidays can be sort of a low time for people. And so, if that is you, I just want to encourage you, please talk to a trusted friend or family member. Talk to a pastor if you have a pastor that you trust. Talk to your primary care doctor and maybe ask for a referral to someone who can help you. And as Dr. Jonathan said, act sooner than later. Don't wait because it takes time to get that referral and to meet with somebody and if they're going to go the route of medication to get to the right medication and the right dosage. And so all of those things take some time. And so the sooner you act, the better. And please advocate for yourself. If you are referred to somebody and you don't feel comfortable with the care that they're providing, or you would like somebody who is offering a little bit more talk therapy and not just medication, advocate for yourself. It's okay to ask to see somebody else. And as you are dealing with some of your depressive symptoms, find things to do. I know it's hard because you're probably suffering from very low energy and very low motivation. And there's probably days where it's all you can do even to get out of bed. But just as Dr. Jonathan advised, try to schedule things that you can look forward to, things that you know that you're good at, that you have mastery over, even if they give you less joy than they did in the past. Even if the amount of joy that they give you is just like the tiniest bit, but hey, that tiniest bit of joy is better than nothing. And so if I could push you a little bit, try to schedule some things that you enjoy, that you used to enjoy, even if the benefit that you get from it is just incremental and tiny. To close, I just want to pray a prayer of benediction over you guys. May the Lord Jesus Christ, God the Father, and the Holy Spirit be with you and upon you. May his face shine upon you and keep you. And may you know that he is with you always, and you are never alone. And so thank you guys for listening today, and we'll see you next week. For more Daily Sabbath content, please be sure to follow us on Spotify or wherever you get your podcasts. And you can also follow us on our Instagram account, Daily Sabbath.